This is Listen St. Louis with Carol Daniel. When I think about the critical issues facing Black and Brown residents in the St. Louis area, I often ask the questions: how did we get here? What's holding us back? And how do we progress? At 9 PBS, we want to deepen our understanding and change the narrative. Join me as I look for answers and discover solutions on today's podcast. 5 years ago, 11-time Olympic medalist Allison Felix had an emergency C-section due to severe preeclampsia. The quick thinking of her doctor likely saved her life. But the Centers for Disease Control and Prevention says too many women die each year in the United States from complications related to pregnancy or delivery, and too many of them are Black women. Today on Listen St. Louis with Carol Daniel, the CDC says the Black maternal health crisis is a state of emergency. Why is that? And what can be done to turn it around and save more Black mothers and Black babies? That's today on Listen St. Louis with Carol Daniel on 9 PBS.
Listen St. Louis with Carol Daniel is supported in part by Midwest Bank Center, the Betsy and Thomas Patterson Foundation, and Orvin and Latrice Kimbrough.
Welcome to another episode of Listen St. Louis with Carol Daniel. Thank you so much for tuning in. And before we get any further, I need you to like and I need you to subscribe because it will prove to them that this was a good idea here at 9 PBS. And please share this podcast. So many of you do that because you know when you listen to it, you like it, and you want other people to be made aware of these incredible conversations that we are having here at 9 PBS. Here we want to change the narrative. That is the story we tell ourselves about ourselves in St. Louis. And that is certainly true for the African American experience in St. Louis. And so today is one of those issues. It's an international issue, it's a national issue, and it is a local issue. The names are too numerous to recite. The number of Black women who die due to complications of childbirth. What we know is that Black women are nearly 3 times more likely to die after giving birth than non-Hispanic women. And regarding uterine fibroids, Black women are more likely to develop them and at early ages in life than white women. To help us make sense of it all, and to give us some hope, she is a history maker indeed. Joining us, Dr. Dineo Khabele. Thank you so much for joining us on Listen St. Louis.
It's my pleasure to be here. Thank you for inviting me.
You are officially, let me get this right, the Mitchell and Elaine Yanow Professor and Chair of the Department of Obstetrics and Gynecology at Washington University School of Medicine here in St. Louis. Mm-hmm. And I said you're a history maker. You are a first.
Yes, first, but hopefully not a last. So I'm the first Black person to be a chair of department in the School of Medicine at Washington University. So definitely a first, but not a last. And we have another a Black chair of Department of Emergency Medicine, Dr. Opoye Adeoye, who followed quite soon after I was appointed to this role. So
I'm a fly on the wall. What was that decision-making conversation like when you either apply or they come for you? I don't know which happened, but what was that like?
Well, it was an opportunity that I really couldn't refuse because of the mission, because of, there was a conglomerate of events that happened. It was, the history of St. Louis in general, and the history of the United States, the history of Ferguson, the history of the new chancellor who made this call that Washington University wasn't just going to be in St. Louis, it was going to be for St. Louis. And now we've tacked on with St. Louis. As an OBGYN and a gynecologic oncologist, I specialize in women's cancers. My passion and advocacy is to change the narrative particularly for marginalized and Black women and Black people. And this is an opportunity to make an impact from the middle of the country. Mm-hmm. A lot of the issues we're dealing with in St. Louis are not unique to St. Louis. Right. These are the same issues of redlining, systemic racism, lack of access to care, poor education, lack of access to health care, and a workforce that needs to change to better reflect the patients we take care of, those are issues that if we can find innovative ways to solve them in St. Louis, we're going to make a huge impact for the rest of the country. So that was the call. That's the mission. That's why I'm here.
Any physician could be in private practice, not necessarily educating other physicians. Why that decision for you?
Well, it's a combination of what we do in academic medicine. We call it the tripartite mission. So it's not just delivering clinical care to patients, but it's training the next generation. And then it's really the research to advance the field. And so, those are the things that Washington University in St. Louis offers, and that's what brought me here.
Because you are a physician scientist.
Yes.
What does that mean exactly?
So that means not only do I take care of patients, but I also have a laboratory where we're studying new drugs and new ways to treat a very difficult type of cancer, ovarian cancer, that's usually diagnosed when it's not in early stages, when it's already advanced and it's spread. We have really good chemotherapeutic drugs that we use right now, but a lot of resistance to the drugs we have available exists. So my lab works on finding new ways to overcome chemotherapy resistance. So it's really a range of things that I do, and I really love my job. I also want to make sure that people understand that being a doctor is not just taking care of the individual patient, but also thinking about how we can make things better for a community.
I will never forget, and I just thought of this just now as you were talking, that growing up, my neighbor's mother, who was a beloved person on our block, died of ovarian cancer.
Yeah.
And I was in my 20s, I'm in my 60s now, and I learned then no symptoms.
There are very few. Well, there are symptoms, but the symptoms can be confused with so many other conditions. Okay. Abdominal bloating, trouble eating, getting full early, trouble with bowel movement. So that could be gastrointestinal upset. That could be colon cancer. That could be something else. And so we try to educate the public that ovarian cancer is not that common, but if you have those symptoms that persist, it's important to see your doctor so we can do a workup.
One of the most heartbreaking stories when we talk about Black women, Black maternal health, and Black women dying in childbirth is that of Kira Johnson, who, according to her husband's lawsuit, was allowed to bleed to death, even as he, for hours, he has said, he's done interviews, he's testified on Capitol Hill, for hours begged for intervention from medical staff and was ignored. That's one of the most heartbreaking stories. I had to stop reading.
Yeah.
And as a journalist, I've heard of all of the stories, but when you Google Black women dying in childbirth, the list is far too long. How did we get here?
Well, there are lots of reasons why we got here, and I spoke about some of them earlier. Systemic racism. I think that, part of changing the narrative is to having dual kind of understanding. First of all, this exists, and it's horrific, and it's horrifying, and these stories persist. At the same time, they are rare. They're not that common, and the vast majority of Black women deliver beautiful Black babies with no problem, because delivering a baby is part of giving birth, is natural, physiologic. It is part of what human beings do.
We're built for it. We're
built for it, and we do it. And most of the time, it works out right. But these rare instances when it doesn't work out, we have to really examine those cases very carefully. And what we see is a lot of near misses. What we see is people who don't die, but who have horrible experiences. And part of the reason is because, Black women are not listened to the way they should be. We don't have the right type of workforce that looks like the people we're taking care of. And even if, we try to increase the numbers, it's going to take years to get parity. So we need to educate people who don't look like the patient population on how to best take care of people and how best to listen.
Is that where the phrase culturally sensitive comes
Culturally
in?
Sensitive. I mean, we keep changing what these words are, and it comes in and out of flavor. And, DEI is now out of flavor, but it's the same central concept. How do you deliver care where you're listening deeply, you're understanding the circumstances the patient presents to you with, and then you know how to offer interventions that you would offer anybody else in that same circumstance. It's really quite simple, right?
Right.
That we have we have to put these labels on it, and we actually have to do a lot of cultural work beyond just cultural sensitivity, but just how we deliver care in the United States.
And I want to unpack cultural sensitivity a little more, because at the same time, I am a woman. But I'm a human being.
Right.
And my heart's in the same place.
Exactly.
My uterus is in the same place. My kneecaps are in the same place. So treat me the same.
Right. So this is why we try to separate the issue of racism and understand race consciousness as opposed to being labeled as a Black woman is more likely to die because of biology. We know that's not true.
Right.
It's not race because of biology. It's racism because of social determinants of health, redlining, lack of access, discrimination. Those are the things that we need to separate out. And if you treat the person as a human being and separate that, you're more likely, pain is one issue. So people think it's very deeply embedded that Black people don't experience pain the way other people experience pain. So if you just stop and just say people experience pain, we have the same nerve endings. People experience pain, then you're not sort of prejudicing a person who's complaining of pain.
Folks listening and watching, and I'm still trying to wrap my brain around the notion that someone thinks that I don't feel pain or am less likely to.
Your threshold for pain is higher. Right?
Mine's actually very low.
So exactly. So these are these prejudices that, and I've written about it with my own birth story. I gave birth in New York where I trained, the very same hospital I received my medical degree, and just happened to live in Harlem. And came in labor, early labor, with my husband. We have different last names, right?
That's all right already.
First of all, different last names. Harlem address. So it's not even the physicians. We start with the person who's checking you in. So already she made a whole bunch of assumptions about who I was.
You're a baby mama.
Right. And he was the baby daddy. And
so you're less than already.
So do I need to be drug tested? Do I need all this stuff? And they had me sitting in triage for a very long period of time. And then my husband calmly had to call for my physician, who just happened to be a very prominent physician, Black woman, who wasn't on call. And I didn't want him to call her because I know what being on call is like. And he quietly got them just mentioned, and she came in and everything changed. And that shouldn't have had to happen
at all.
I should have been treated like anybody else. And so, but I had an MD. So imagine without that privilege.
Right.
These are the stories that happen over and over again.
And by the same token, you do everything right in life, and yet you still are mistreated.
It's not a protection. My degree does not protect me.
No. Has medical school? Well, I guess I have to go back to slavery, but.
Yeah. Well, medical schools are changing, and
I was going to say, has medical school fallen short? But
medical schools have fallen short in the past and are recognizing. So our curriculum, for instance, at WashU is really changed quite a bit and incorporated in the curriculum are whole sections talking about social determinants of health. But you have to understand, culture change is slow. Right? So you have young people who are eager to learn about this and who are, demanding that we do things differently. Well, you have people who've been in practice for very many years who have to kind of adjust to it. Our patients are also more aware. 30 years ago, patients really didn't question their doctor.
Right.
Now we have people who, and I think it's better, you're more educated about your own body. You're looking things up. We can Google a lot of things, right?
I'm WebMD all over.
So then you're going to come to the doctor with really very reasonable questions, and we need to be prepared to address those questions and concerns in ways that are not dismissive, and in ways that we may have more information about a particular condition, but you have more information about what your body does or doesn't do.
And I'm curious if a birthing plan helps, and describe for people who don't understand what a birthing plan is, and if that would help to minimize the possibility that anything would go horribly
Well, even
wrong.
before the birthing plan, a couple of things are really important. Prenatal care, early prenatal care is really important because that allows you to establish a relationship with the people who are going to be taking care of you while you're giving birth and after. Second thing is to develop a birthing plan in collaboration with your providers, the people who are going to be taking care of you. The third thing we know through the literature is having a doula, a person who is trained to be a second set of eyes and ears and a mouth for you at delivery. And then the fourth piece of this is that after delivery, we know the most vulnerable time is when you go home. So what I'm very excited about for the state of Missouri, along with many other states, they've extended that postpartum, the post-delivery period, not just to 6 weeks, but to an entire year.
Right.
Because that's actually a time where a lot of women are vulnerable for complications and rarely, but sometimes even death. So, extending that time period is really important. So the four things that I think people need to consider is early prenatal care, developing a birth plan in collaboration, having a doula, and getting that care extended.
Has the medical community, it would seem, has changed its acceptance of and recognition of doulas?
It's very slow, but it is recognized. Most of the hospitals, I would say all of the hospitals in the St. Louis region, are welcoming of doulas. I think we need a lot more education of individual physicians and providers, perhaps, on the role of the doula. I think we can develop better relationships with the medical establishment, and that doulas are part of the care team, and educating the public about the importance of a doula. But it's becoming more and more accepted.
What does a doula do, and who should have one?
Well, I think a doula is almost like a patient navigator and a person who's really just focused on the patient herself. You can't always have your family member be your doula because your family member is kind of probably almost a second patient, really worried and concerned about what's happening, right? And so the doula is a person who helps you breathe through labor pains, who brings you, water if you need it, who helps educate you about the process. And so doulas are trained about the labor process. So they have a sense of what's going to happen, and they can help you communicate with your healthcare provider as well. In a way, if you're in too much pain to do so, your doula can speak up on your behalf.
One of my husband and I have two boys, and they are 24 and 28, and so my birth story is that old, right? But with the oldest, the nurse came in. I learned later that she was new, and I don't know how long she had been a nurse, but was new at the hospital there. They were both born here in St. Louis, and she came in and she looked at the EKG.
The read for the baby strip.
Yes. Yeah. And then my husband walked over to look at it, and I heard him go, And I said, well, what does that mean? What does that mean? And he said, well, this line on top is, wavy, and the line on bottom is kind of not. And then the nurse came back in, and he pointed that out to her, and she didn't say anything, and then she just left. See your eyebrows furrowed there? Yeah, that was what I felt like. She just walked out. And then 6 people come in. And they're murmuring and they're talking at the foot of the bed. They're not saying anything to me.
To you, yeah.
And I said, somebody better tell me something. And then they said, well, it seems that every time you have a contraction, the baby's heart rate goes down. So we're going to do an exam and find out what's going on. Well, he had the umbilical cord around his neck. Yeah. And I left that experience thinking, why didn't the nurse recognize that was a problem? I don't know if that's because I was Black or not. I have no idea, but it just wasn't the correct response to what could have been a fatal situation. Yeah. And we had to ask and point out that this was an issue. And then to come into the room. Customer service is a part of...
That's part of it. And I think that one of the the issues with healthcare in the United States is we're really, really good at rescue. We're really, really good at, if you have a catastrophic event to come in and swoop in and kind of save the day. But what about basic just, how do we talk to people in a kind of basic kind of way? All the nurse had to say is, oh, it looks like this is what's going on. I'm going to go and talk to the team and we'll bring people in. Don't be alarmed. There'll be several people in. This is who's going to come in the room.
Right.
And the people come in the room and they could say, okay, we're here because this is what we see. These are the things we're going to need to do. And they could have had that little caucus outside of the room and not in front of you, right?
Right, because everyone who came in, I had never seen before.
Right. And introduce basic things. Hello, my name is Dr. So-and-so. We're here, and this is my team. These are the people on my team. This is who they are. This is, so I'll introduce my team. I'm going to have a fellow, a first assistant. I'm going to have a student doctor who's going to be observing me today. This is my team. These are the people who go around with me when I make rounds in the hospital.
Would have taken all of 30 seconds, and I would have been...
or less. Exactly.
I would have been comfortable. So we're going to talk about uterine fibroids as well, but before we move on to that, so what is the advice you give to Black women who are giving birth? I, for one, wanted a Black OBGYN because I thought that, and this is, again, 28 years ago, 29 years ago, I thought that would minimize issues, and I felt that I would be heard. Yeah. So, and we weren't talking Black maternal death rates 29 years ago.
Yeah, I mean, that's really important, but think about our workforce. There's so few of us. Yeah. So, and many of us, people are lining up. We don't have space in our practices. There's so few of us. So, if you can, that's wonderful. It doesn't always guarantee, right? Just because you're a Black woman doesn't mean you're going to be empathetic either.
And she's not necessarily going to be there the entire time of your labor.
So I didn't put that in one of my 4 strategies.
You did not.
I did not, but part of my role as a chair of the Department of OBGYN is to identify and to try to train additional people who Black women who would be interested in this field so that we can increase the workforce, diversity of our workforce. So that's something I think about a lot. And then, again, I said earlier, it would take, 100 years plus to get to parity. So we have to work on people who are not Black women to understand the issues and to deliver the kind of care that we really deserve and need.
So I do want to move on to talking about fibroids. I've had them. I've had some removed. Black women in the United States up to 3 times more likely to develop uterine fibroids than white women, tend to develop them earlier in life by age 35. About half of Black women have had fibroids by age 50. 80% have had them. Black women also tend to have larger fibroids and more of them that can cause severe symptoms. First of all, without us going to fibroid medical school 101 class, what is a fibroid?
A fibroid is a growth in the muscle wall of the uterus or the womb. So it is not a cancer, but it's a growth. It's a tumor that's not a cancer, and it's a whirl of a mass from the muscle wall of the uterus is basically mostly a muscle because that's how contractions will allow for birth of a baby. These are just non-cancerous growths of the muscle wall. They can grow really, really large. They can grow bigger. They can allow the uterus to grow bigger than the size of a pregnancy, of a full-term pregnancy. Right. The severe symptoms can be pain. Severe symptoms can be bleeding. And what we see a lot, which we need to educate people about, is that the bleeding, heavy menstrual bleeding from fibroids is not normal. And so many women live with these symptoms because their mother had heavy periods and their grandmother had heavy periods, and it's just something that happens in our family. Right. We don't really talk about it. But I've had patients who walk around so anemic that's increased their risk of heart disease.
Oh my goodness.
Because their heart is working overtime to get oxygen to their body because they don't have enough blood circulating because they're so anemic.
Wow.
Because they've been bleeding out every month. So we now know there's so many medical options for treating fibroids, including oral contraceptive pills, hormonal shots. There are other ways surgically to remove fibroids. And then at some point, if they're so symptomatic, a hysterectomy or removing the uterus is a viable option. The problem is we see, that some women are not even offered medical therapy and are offered straight to hysterectomy. Mm. And then some women that I see, I get my practice, I see a lot of people who've had more complex fibroids and who've been through medical therapy, but they don't want a hysterectomy as Black women because they somehow feel that that's going to sort of change who they are as a woman, and yet they're bleeding out and have pain and symptoms. Mm. So we have these two extremes that I feel like we could do a lot more education on.
And what makes for a complex fibroid?
Well, where it gets so large, where that it gets stuck to other organs, or it's compressing the bowel or the bladder, or it's so huge that we can't do a little Band-Aid surgery, minimally invasive surgery. We actually have to do an up and down procedure because the uterus is becomes so huge, and the risk of bleeding from that particular surgery is high. So we'd rather identify these early on, try to treat them if they're not treated medically, and at some point they still have bad symptoms, then hysterectomy is an option.
Mm-hmm. And I said in reading those statistics that Black women are developing them earlier.
Yeah.
Is this, you are, as I mentioned, a physician scientist, so you specialize in ovarian cancer. Yeah. So you are the one to talk to about this. But how much study is going on, and how much understanding do we have?
Well, this is where we need the public to kind of rise up and say, why do we not have enough funding for women's health? I've sort of told you the basics about fibroids, but we don't know why some grow to the size that they do and others cause bleeding. Why are some in certain parts of the uterus versus others? Very rarely are they associated with cancer, but they cause really significant symptoms where women are out of work, or sometimes have difficulty getting pregnant, or the fibroids are so large, maybe they're impacting that pregnancy. So we definitely need more funding. There are people around the country, including at WashU, who are studying fibroids, but we need more funding and more people to have an interest in it.
My niece just had a baby, which we are so thrilled for her and her husband. But she, I learned, had fibroids in her 20s, and the doctor said, don't worry about those. Then she gets pregnant, and the doctor says, why didn't you have these removed? Because we need to monitor the growth of your child, because they apparently are of a size that it could impact the development of the baby.
Well, if the fibroids are small and not causing any symptoms, you just read the statistics of how common they are. Fibroids are common amongst Black and white women. Fibroids are really very, very common. And people can develop multiple fibroids and it's not a problem. But once they get to be very large or cause significant symptoms, then maybe one option is to remove them. They can grow back, though. So those are the things that we have to really pay attention to. Again, we don't know why some people's grow back, and other people we remove them and they never come back.
Do we not know why Black women have them and have them at earlier ages?
We don't. There's some research looking at environmental factors. They're very hormonally driven. So is it something in more industrialized areas where Black women are growing up, or is it in our food? Those are theories that are out there, but we don't know precisely why.
Well, I am not happy that we don't know why something that affects Black women the way that it does and affects your life. When you are calling in sick, when you are in pain all the time, is this an issue of I hate to say it, but apathy? I mean, we're only going to study what we care about.
I think it is. And a lot of us around the country are really raising voices and really delighted that the president and the first lady really rallied this year to allocate additional funds for women's health research. Because, one of the things that I talk about is I'm thinking of your neighbor, you said, who was just this pillar of the community who ended up dying of ovarian cancer. If you can do right by a woman, you're not just doing right by her, but also her family and her community. So it's a good investment to figure out what's going on with women's health conditions and diseases, because you can make a huge difference for the nation.
We say we love women, or do we? I mean... Are we not saying that we love women, that we care?
Well, you can't have healthy babies without healthy moms.
Right.
And, this is the thing that I try to tell people.
And what is if it's an indelicate question, I apologize to those of you, but is pain during sex a sign?
That could be a sign as well, yeah. Or just constant pain, like severe menstrual cramps because of the bleeding. Or pressure. These can get to such a size that they're pressing on the bladder, so then you have to go to the bathroom a lot, or they're pressing on your bowels and you become constipated. So there are a variety of symptoms that can occur from fibroids.
And because we apparently aren't studying it enough, so we don't know why more black women, why earlier in life, why some grow back, we don't know why, then do we not know how to prevent?
Right, exactly. So we don't know how to prevent. We do know how to treat. We're getting better with treatment. Like I said, we're not going straight to hysterectomy. We have lots of hormonal therapies, medical therapies that help. There are also some therapies where we can ablate or kind of decrease the size by a uterine artery ablation by stopping the blood supply. But that's only in somebody who doesn't want to become pregnant, because you want a good blood supply for the womb if you become pregnant. Right. But those are different strategies we can use before definitive hysterectomy. And we can also do myomectomy, where we just remove the fibroids. But again, some of those grow back, and we don't know exactly why.
Are we alarmed? Is this an alarming thing, or maybe we're not alarmed enough?
Well, I don't know if the word is alarming. It is serious. And I think the impact, we have to change the narrative in how we're describing this, because, it is not a cancer, but the impact it has on the workforce, on communities, but we're talking about something below the belt. We're talking about menstruation, bleeding. We're talking about a gynecologic condition. And so I think we have to erase the stigma. People need to not be offended when we're talking about, gynecologic issues, so that we can really examine and study it. The other thing I would say is, if we're going to study something, we have to be able to conduct clinical trials.
Which means participation
in clinical trials. And so that's something that, we have to do a better job of.
And there's also the notion that we as women already don't take the best care of it. We are not even on the list. We talk about putting yourself on the list,
right,
and self-care, but we have to first put ourselves on the list and take better care of ourselves. And I say that knowing that a lot of women don't have resources, and the stress that far too many black women face in their lives is great.
It is, but, it's put your oxygen mask on first. You really can't help other people if you haven't helped yourself in a certain kind of way. And unfortunately, in my practice, I see so many women who come to me where they have not taken care of themselves for years. They deliver that last baby. When was the last time you had a pap test or seen a gynecologist? After I got my tubes tied 20 years ago.
Oh my.
So, there are other parts down there below the belt, beside,
Right.
We still, and so we see that people just kind of neglect, because they've delivered their baby, they've had their tubes tied. don't need to worry about it.
And not true.
And that's not true. That's not true. And also, I think as a society, we have to say it's okay for you to take some time for yourself, because I think it's embedded. I mean, it's deeply embedded in me that I'm going to run and do stuff and save and
right.
you know, when am I going to stop for a minute and it's okay to take a nap once in a while, right?
I am not at all embarrassed to admit that there was a point in my life when other friends a couple of them had hysterectomies, and you know, I think one girlfriend said that she was out for 4 to 6 weeks or something. And my first thought was,
that's a rest, right?
I thought, could I get it? I don't even need one, but can I get one just so I can get 4 to 6 weeks off? That is indicative of the life that far too many of us are leading.
Yeah.
What a message that is.
I know. Well, I think we have so many opportunities to change the narrative. I love that phrase, change the narrative, because we have to reframe so many things and reimagine what this is going to look like, which is healthcare doesn't have to be what we've made it now. It could be something different. And I think the introduction of patient navigators in labor and delivery as doulas makes a big difference. And that's okay. That's a culture shift in medicine, and it's okay, and we're embracing it. We're developing it, and I think it's going to help people.
We so want women to know, and men, that you matter.
Yeah.
And I so want Black women to know that you matter, and that all of our behavior should emanate from that central notion.
Absolutely.
That I matter. So everything about me matters.
It does, yeah. But the narrative is that we don't matter, right? So we have to reverse that.
Exactly.
That's, again, changing that narrative.
And that is why I wanted you to come on today.
Well, it's been a pleasure.
And she's fresh from surgery, first of all. Let us just say that she had a surgery this morning, and it was well.
It went well.
And
yes,
it went well.
Yes,
so thank you so much for joining us.
My pleasure. Thank you for inviting me.
So our last bit of advice, just take care of yourself. But in terms of a healthy pregnancy, a healthy delivery.
Yeah. Early prenatal care, developing a birth plan in coordination, having a doula, and following up a year after you deliver.
That is it. Thank you so much.
Thank you.
And thank you for joining us for another episode of Listen St. Louis with Carol Daniel. Don't forget to like this episode, and don't forget to subscribe. You can also share, and please leave us your comments. We especially respect and appreciate those. And let us know if there's another topic or a guest that you think we should have on the podcast. We will definitely endeavor to get them right here in that chair. Thank you for listening. Have a great day. We'll be back with more Listen St. Louis with Carol Daniel.
Listen St. Louis with Carol Daniel is supported in part by Midwest Bank Center, the Betsy and Thomas Patterson Foundation, and Orvin and Latrice Kimbrough.